Welcome to Arch Ghost, the show focused on creating high caliber, adaptable, and prosthetically driven full arch surgeons. The surgical techniques described and depicted in this podcast are provided by Arch Ghost LLC solely for informational and educational purposes and are intended exclusively for properly trained, licensed, and clinically competent healthcare practitioners acting within the scope of their professional credentials. As a licensed healthcare practitioner, you alone assume full responsibility for all clinical decisions, actions, and outcomes as part of your patient care. Please see our full legal disclaimer at archghost.com/disclaimer. Today, we're going to talk about full arch pearls, thoughts, and reflections, part 1. So this is going to be a 2-part episode. This is actually an article that I wrote. I think this is a newsletter, to be honest, that I wrote a couple years ago. And I just thought it had so many good tips and pearls that I wanted to bring it on the podcast and kind of dissect it where I could talk a little bit more in detail about each of those items because the newsletter itself was quite brief. So we're going to go over those and dive a little bit deeper into them. So today we're going to cover 10 full arch pearls, thoughts, and reflections. And then the next episode will cover the next 10. So number 1, resist the temptation to offset less full arch experience by placing more implants per case. This is something that I see consistently amongst newer full arch surgeons. And this is the idea that you need more implants to make a case work. And I feel that often a lack of confidence or maybe understanding there's this inherent desire to cover that by placing more and more implants to try to make the case successful. Sometimes that can actually have a negative impact when implants are either too close together or if you place an implant in such a way that it can actually prevent being able to strategically perform a remove and replace in the future in an area that you want to. So the message here is really that evidence-based research has shown us that 4 implants is sufficient for successful full arch surgery. Now here's the catch, if torque and spread are adequate. So if you have little to no cantilever because of adequate spread, which I define as a cantilever of 1 tooth or less, and you have adequate torque, research will show us 120 Newton centimeters. I do, and I have discussed this before, I do try to get a torque of at least 45 Newton centimeters or higher per implant. So for me, for a 4-implant case, I prefer 180 Newton centimeters of torque. That's not necessarily evidence-based. That's higher than what the evidence-based protocol is. But I feel anecdotally that provides a higher integration rate and more room for error in terms of if something has a subtle occlusal discrepancy or the patient maybe isn't as adherent to their diet. I think that gives you some leeway. But if the torque is adequate, if the spread is adequate, 1 tooth cantilever or less in my hands, I just perform 4 implants, and I have for thousands of arches. And it is not necessary to perform more than that, in my opinion. Now, I'm not opposed to more than 4 implants if the case dictates it. If I cannot achieve a 1 tooth or less cantilever, or if my torque is not adequate, then I am going to place additional implants to achieve an adequate torque, to achieve an adequate spread and an adequate cantilever. But the message that I think I want those of you that are newer to the field to hear is that the priority is AP spread and the resultant cantilever, and your composite torque value, the torque of your implants. That is what should dictate the number of implants you place. Shouldn't just be an arbitrary need to place more implants. So I challenge you with that. You know, and again, I don't think like somebody's a bad surgeon or that it's wrong, if you decided you wanted to place more implants. But the thing that I always think about is you ultimately are performing extra unnecessary surgery on the patient, which could incur extra unnecessary complications. It's also creating a procedure that takes longer, which we do the procedure under general anesthesia. So we're subjecting our patient to longer general anesthesia times, which can also incur complications. So I want to perform the right amount of surgery, as much surgery as needed for the patient to have an optimal outcome. But I don't want to just arbitrarily perform extra surgery because maybe I'm worried or insecure about the case, and put the patient at risk of those other things if it's unnecessary. If it's necessary, again, because torque or spread is inadequate, that's different, in my opinion. Number 2. If you elect to perform a delayed load and bury your implants, remember to check abutment angulation and position, correcting implant timing if necessary, before you place cover screws and close. This is something that we all often forget, and I am guilty of this too. That's why I put this on here. Fortunately, we don't bury a lot of cases, which is probably one reason why we forget this when we do. But if you bury your implants, you bury your arch, let's say you place 4 implants, and you for whatever reason, you're going to bury them and then load the prosthetic 4 months down the line. It's easy to just place the implants and then put your cover screw on and forget to check your abutment angulations. And what happens is the implants will then integrate in that position, obviously. And when you come back to do your conversion in 4 months, you might notice that your implants are not ideally situated for your abutment angulation, and your abutments might be angled in a less than ideal way. And there's really nothing you can do about it at that point because the implants have integrated. So if you bury your implants, remember, place either an abutment or an abutment. Some of the kits have like a little abutment trial indicator thing. Use one of those things to check your abutment angulation and change the implant position or timing if necessary to get the abutment where you want it. Then take the abutment off, put your cover screw on, and bury the implant. And that will avoid that problem. Number 3, always have an extra implant stash, or what I call a go bag, of commonly used implant sizes on hand with you, either in or near the OR or your operating room. So those of you that do a lot of full arch surgery will understand this, but those of you that are new might not. When you do maybe a single implant case in your office, it's common practice to plan the case and then make sure you order that implant size. Maybe you're going to place a 4x11 implant. You just make sure you have a 4x11 implant on hand. Well, with full arch surgery, if you're going to immediately load, you need to have a variety of implant sizes on hand to ensure that you can adapt and change as the situation indicates, which might be a larger implant, a wider implant, a longer implant, a smaller implant than you thought. All of those things you need to be ready for. But I have found it just extremely valuable. I take basically 2, I guess it's like Noah's Ark. We take 2 of each kind and put them all on there. They all get on the cart and go into the OR area, but two implants of basically each and every size that we ever use, I have available just right outside the OR there, so that let's say I get into the surgery and I thought I was going to do we're doing a single arch and I was going to do 2 4x13s, in the posterior, 2 4x11s in the anterior. And once we do our reduction and I start drilling my osteotomies, the bone's softer than I think. And I say, you know what, I'm going to use 2 5x13s and 2 4 3x11s. Instead, then my team doesn't have to run all the way back to the implant cabinet or wherever you guys keep your implants. They just, we've got it right there, easily accessible. They grab those, open them up, and it takes all of an extra 5 seconds. But I find that to be just a neat little hack. It sounds obvious if you have been doing it or if you do it, but for those of you that don't do it and your team is constantly running, out somewhere for 2 or 3 minutes trying to get you an additional implant, that'll be a game changer for you. So always keep an extra implant stash or a go bag right outside your OR. Number 4, the Panorex image is your best full arch treatment planning friend. Obviously, the standard of care is a CT scan. You can't do these cases without a CT scan. That being said, I do 80% of my planning on the Panorex image. There is so much that you can tell from a pano in terms of, for freehand surgery, there's so much you can tell in terms of freehand ID points. This is where you're going to locate your sockets or your bone irregularities or your canine apex or the position of the sinus. All of these things are easily visible on the pano, and the pano gives you just this eagle's eye view of everything that really allows you to quickly, easily make a game plan for your arch and really do, again, 85% of your treatment planning right from there. So I challenge those of you who don't use the pano as an implant planning tool to rethink that, because it's so valuable for full arch surgery. Number 5, many very experienced full arch surgeons become slightly more conservative with time, not slightly more aggressive. Food for thought. So I've seen this play out a number of different ways with a number of different providers, including myself. And I've always found this interesting, but I think there's this assumption that the more you do, the more aggressive of a provider you'll become, meaning you'll just tackle every case. And I find that opposite of that to be true with myself and with many of the more experienced full arch surgeons that I've become acquainted with. Yes, from a surgical technique standpoint and a surgical difficulty standpoint, I think the more surgery you do, the better you become at those cases. And, there's really not a lot from a difficulty standpoint that I won't do, but there are patients that I've come to learn over my experience not to treat or to avoid. And a lot of those come down to patient psychology and the ability of the patient to tolerate the procedure or be willing to handle some of the potential complications of the procedure. And also medical management and knowing really which patients can tolerate this procedure and which can't. And I think that the more you progress in your career and the more you manage and see some of these complications, the more you kind of step back a little bit in some of those areas and proceed with a little more caution. I also see this play out like almost to a T with, OMFS residents, right? When they come out of residency, I've seen time and time and time again, OMFS residents that start doing full arch surgery, they're hot out of residency and doing a lot of big surgery in residency, and they're willing to do anything. I mean, they will tackle any case you throw at them, and then within 3 to 6 months, they've had some some pretty decent complications and things fail and not work. And then they go to this point where they really drop off and get conservative and oftentimes even get a little bit afraid to do certain things, or afraid's not the word, but worrisome and really hold off. And then over the next 3 to 6 months, that kind of levels out and they progress back up to kind of a happy medium. So the point being there is just that know that with time and with experience, you will see things that you don't want to do, or you've learned are not wise to do, and that's okay. As I've always said, you don't have to treat every patient. Not every patient is a good candidate for this surgery. Obviously, we want to treat as many patients as we can, and we want to be able to treat most everybody, but there will be patients that you'll see a reoccurring theme that, hey, this type of patient, this one's maybe not the best. And so as you get more experience, listen to that inner voice, because I find that with experience, many of the best surgeons actually do become a little bit more conservative in certain areas, and it's for good reason. Number 6, the most important contributions a surgeon can make to a full arch case are achieving great torque and solid AP spread. We've talked about this many times, but as a surgeon, those are your 2 primary responsibilities. That's your job: torque and spread and torque. Being able to achieve a spread that delivers a 1 tooth or less cantilever, and being able to achieve consistently high torque, that is going to lead you to a significant successful integration rate. If you cannot consistently deliver those items, as a surgeon, you are not consistently doing your job. Sure, there will be cases where we can't. There are cases where I can't. Not everything is going to be perfect, but that is our job as the surgeon. We do need to deliver those 2 items, and that really needs to be our mental focus when we walk into the case. How do we generate AP spread? How do we generate torque? That is our job. Number 7, the most important contributions a restorative doctor can make to a full arch case are achieving balanced occlusion and limiting the presence of a cantilever. So just like the surgeon has 2 primary roles, the restorative doctor has 2 primary roles. And their job is to deliver a balanced occlusion and limit or eliminate the cantilever. Now, occlusion, that is incredibly important. If you are not able to consistently deliver a balanced occlusion, and you put unwanted, undesirable, off-axis, occlusal forces on freshly placed implants, you are going to see a higher than ideal failure rate. It is very difficult for a well-done surgery to overcome a poorly done prosthetic. The poorly done prosthetic, the poor occlusion, those less than ideal consistent forces over time usually win and result in an implant failure. So doing that job is incredibly important. The second aspect of that is limiting the cantilever. Now, spread is the job of the surgeon, but spread and cantilever are different. The restorative doctor has the fortunate and unfortunate role of coming after the surgeon. And so they have to respond to whatever spread is provided. Now, if your surgeon is consistently not providing you adequate spread, that's a surgical issue. But on a, limited case basis, if you're given a case with less than ideal spread, that ball is in your court to determine what you can do on the restorative end to limit that cantilever. There are a number of techniques that we'll discuss in our courses and other lectures and things, but being able to say, okay, I've got a less than ideal spread. How can I limit that cantilever? That is a choice, not an easy one and often a difficult one for the restorative provider, but that is a choice they have to make. And they determine what cantilever they're going to put on there. If they're going to put a longer than ideal cantilever on there, they are doing that with the knowledge of what the AP spread is. They're making a conscious decision to do that. Ideally, a conscious decision is made to maybe shorten the arch or rotate the arch or use a smaller arch or any of these things to help create a more desirable cantilever. Again, this is a team sport, and the surgeon and the restorative doctor have to work together, whether that's in a full arch practice or in a referral relationship. So it's not any one person's fault, but because the restorative provider comes last, again, it's maybe the curse of that role, having to go after the surgeon, but you have to respond to what the surgeon has done. If the surgeon has not given an adequate spread, then that discussion has to be had with the surgeon, but ultimately the decision has to be made on how can we correct that with the cantilever. And so that is, in my opinion, the role of the restorative provider. Number 8, don't celebrate too soon. We should all feel good when we finish an arch, but remember, there is a 4-month marathon that still has yet to be run. I think that this comes back to our discussion on experience, with true full arch experience being arches cut times time. And I think that often too many providers post a picture maybe on Instagram that, hey, I did this case today. It was awesome. And my thought is always, and that's great. I feel good when I do a good case in the office too. I'm not saying that you shouldn't be proud of that. But my worry is always like, okay, well, A, is it going to integrate? Let's see the case at 4 months. And then B, what's that case going to look like at a year or 5 years or 10 years? So this surgery, ideally we only do the surgery once. This product that we've created, it doesn't end on the day of surgery. It has to make it to 4 months, and then it has to make it years after. And so, understanding that and operating in a way in which we try to maximize the longevity of the prosthetic is ideal. And I think that starts with remembering that this procedure isn't done after the surgery finishes. We will all have humbling reminders of that over our career. Number 9, a poorly planned and or poorly made prosthetic will overpower a great surgery any day of the week. We just mentioned this in a different context, but this is just, again, reiterating that an understanding of the prosthetic side, a balanced occlusion, a limited cantilever, all of those things so heavily impact the surgery and the success of the surgery and the prosthetic. And I say this, again, not to ever point blame or anything at a restorative provider. I say this in a 100% way of being in awe of the value that the restorative providers bring to this procedure. The knowledge that is necessary to do this at a high level on the prosthetic side is undervalued and undertaught, and the ability to be very good at this on the prosthetic side so heavily impacts the success of the surgery. And I know that when I've worked with very talented restorative providers, my surgeries perform better. I do better because of what they do for me and what they do for the surgery. So the flip side of that is, and I hear about this a lot, especially in the private practice world, is in working with referrals, the idea that, what the referral does doesn't really matter as long as the surgeon does the surgery well, and it's all the responsibility of the surgeon. And that's just simply not true. I mean, that couldn't be farther from the truth. And so when you're doing these complex surgical cases in your private practice and sending it back to a restorative referral that doesn't know what they're doing, they are likely creating a lot of issues for you and significantly increasing your implant failure rate. So being able to work with or selectively choose people that have experience or provide training to your restorative doctors to really increase their prosthetic knowledge will reap dividends in your full arch practice. Number 10, surgical treatment planning should take 2 minutes or less, not 2 hours. So this was from an article that I wrote, one of the first articles that I wrote on what is now archghost.com. And I really believe this. And again, this is not in any way diminishing the quality. I believe that you can perform the highest level of treatment planning quality in 2 minutes or less for full arch surgery. The idea that you have to do, move these 3-dimensional implants around into 16 different configurations and have a phone call with somebody from another state or country that's going to tell you on a computer what you can and what you can't do, and then ship you a guide, and you got to log in and then confirm the guide, and all this steps that take I hear of these like 2-hour treatment planning sessions. I don't know what is happening in those, but you just need to know the height and width of the bone. That's it. That's all you got to know. So that should take seconds or minutes. And obviously that comes with practice and with time. You're not going to do that your first case. But when you look at these cases again and again and again and again, you really can look at something very quickly and understand what you need to do, both from a surgical treatment planning perspective and also from an implant selection standpoint. But honestly, it really comes down to just measuring the height and the width of the bone. That's it. This other stuff is mind-boggling to me. But so. Those are the 10 points that we're going to cover today on our full arch pearls, thoughts, and reflections. This is part 1. Our next episode is going to cover another 10 points as well. So that's the pod. And as always, remember, operate in the shadows, adapt relentlessly, and load them all.